Hey, everybody, welcome back to the Overrun Podcast. Ed Bowder, Dan Schwester, Mike DiFilippo are here, and we're going to go over the EMS stuff. Today, as we're recording this, we're going to be doing this special episode. And Danny, are there any things we need to talk about, any hard outs that we have today before we start recording?
I've got a hard out. I've got to be done by 7 o'clock because, as you know, this is when the main hatchway gave in.
On the Great Lake, they called Gitchagumi. All right, so the Edmund Fitzgerald is still on the bottom of Lake
Shout
Superior.
out to Gordon Lightfoot.
We did it, you guys.
It was... they rang the bell 30 times, Ed.
30. 29.
No.
Welcome to the Overrun Podcast. All right, so we're here on the show. Dan, Ed, and Mike are here. Remle Crowe is joining us. Dr. Crowe, thank you for coming back on the show.
Thank you for having me.
What's your favorite part of the Edmund Fitzgerald story?
They would have made Whiteface Bay if they put 10 more miles behind them, Ed.
They could have. We're recording this on November 10th. This is all we've been listening to all day is the wreck of the Edmund Fitzgerald. Dr. Crowe is just back from EMS World. She was also one of the principal authors here for Section 4 for the AHA updates. Yeah. Our last episode was talking about the overall updates, and today we're going to get into the systems of care here. Dr. Crowe, again, thank you for joining us. How was EMS World? Did we have a good time? Did we learn a lot of stuff? We talked to you last year after EMS World. Were things better? Did anyone else try and ruin their career in public?
Great questions. No, this year went off without a hitch. It was a very tame but very productive EMS World in Indianapolis. A lot of great things going on. The International Scientific Symposium, or the Gathering of the Nerds, that happens within EMS World was record attended, and we had record submissions this year. So tons of really great posters from at least 9 countries I counted on my little tour, but I think there were more. And there was this guy, Mike, I don't know.
Yeah. Dr. DiFilippo wrote something like that.
There was a few Overrun people involved with those posters. I know because I heard one all the time while the sun
never sets on the Overrun Empire. We are everywhere. Expect us.
That's right.
So
we
talked previously about this AHA update because everyone kind of lost their minds when this all went down. Remle, you were there when the new guidelines got dropped, which was during EMS World, which we talked about this in the last episode, but I love the moxie of just being like, and here we go. And then just kind of walking away and doing the Joker meme, walking away from the hospital, blowing up. But your section was on systems of care. And in going through this whole document, again, this is something we give something like 760 total recommendations. Obviously, we're not going to go through all of them in one episode. And it's varied. There's more than 200 class 1 recommendations, more than 450 class 2 recommendations. It's a really, really dense document. I anticipate, I encourage everyone to kind of go through and read it. So the reason we want to talk about systems things, these are the things that don't cost you any money if we're trying to change and improve the chain of survival and all of our AHA outcomes. Whereas, buying equipment might cost money, changing your dispatch things might cost money. But here it's a lot of just how the system works. So, Remle, talk to us a little bit about what you guys looked at, what you found, and what we can work on.
Yeah, absolutely. So this is definitely one of those things where it takes a system to save a life. And so we started off by thinking, what are the components of a system of care? And some of these are modifiable and some are less modifiable, right? So we came to the conclusion that everything is heavily influenced by the environment. And so we need to take into account that local context. But then there are other components that we should be paying attention to, like the personnel, the quality improvement, which is an area where I get super nerdy and very glad to see that in here. Thinking through equipment, policies, information exchange, all of those things. And so you'll see that systems of care, those different components show up throughout the recommendations within this chapter. And it all really kicks off with that chain of survival. And you probably already talked about, but the chain of survival has undergone a facelift going from 4 back down to 1. And we tried hard to weave the sections in to match with the correct links in that chain.
And so let's just dive right into the chain of survival here, because it has been kind of fractured, and now it's a lot more streamlined. It takes a lot to talk about recovery care, which is a huge link in the actual chain of survival. So let's talk about a little bit about that. Let's talk about what we added to it. And then, Mike, I want to get some of your feedback on what this actually might change in practice.
Yeah, so this was an area where we spent a lot of time as the different writing group teams, not just the systems of care team, but thinking about the different links in the chain. And so the decision to consolidate this was an important one because there were 4 different chains. There was pediatric, adult, in hospital, out of hospital. But ultimately, all of these links apply in one fashion or another, independent of where and what age group. So that was the first major change is consolidating into one. The other part that was debated heavily, and I think it's absolutely correct, was the consideration to add a preparedness link. And so you'll see in the description, the preparedness and the prevention link wasn't added, but it is something that we considered greatly. The consensus just wasn't there on how to best incorporate it, but the need for it is very clear. And the thinking about even something like an early warning score, and you'll see that in the in-hospital recommendations. And I would argue we probably need pre-hospital warning systems as well. And there's some really great work on sudden ambulance death syndrome. So the concept of prevention and preparedness applies in both settings. And I think that's a link that's critical, whether it's visualized in this chain or not. It's certainly something we should be thinking about.
And Mike, let's build out on that a little bit. The old chain of survival was kind of fractured, made things a little bit more complicated. In practice, what do we see? Like, how can we apply this, and what does it change for systems?
I think very importantly, like following the AHA's like ebb and flow on this is sort of the ebb and flow in healthcare in general. I think now we're sort of living in an environment within our healthcare systems that is really recognizing, speaking about EMS, that we're not just some like extra random bucket to be considered. We're actually part of the integrated healthcare system. So I really feel that's probably going to be the biggest impact towards your everyday EMS clinician going forward is probably going to see a lot more step line recommendations with other societies, incorporating the idea of what you may do in the field now could have impact on patient recovery, weeks, months later, could even include maybe responding to the same patient at a recovery unit, things along those lines. So, I think again, the message is sort of the same in some aspects, but sort of zooming out to recognize that there really is, one overarching care theme within AHA's CPR cardiac arrest guideline update is just ensuring good overall care and recognizing that EMS is an integral part of that system, I think is what we're really seeing here. May not, see like an immediate change in what you're doing in the field today or anything along those lines. But I think to Dr. Crowe's point, future iterations, especially the preparedness aspect, I think is actually really important and may see, evolution within EMS clinicians, approaching that aspect. We already do some parts of preparedness, I would say, if you're in a high functioning or EMS system with community outreach CPR, things along those lines. But I definitely think more could be done there. And that would definitely involve EMS. So I think overall, again, it's probably just the consolidation of all of our work together under one umbrella as opposed to fragmented in a way that it used to be.
I think the preparedness thing is a huge piece, especially because whenever these updates come out, right, we view it from the EMS lens, but they're obviously not EMS interventions. Right. We talked about this in the last episode too, where this is just cardiac arrest kind of across the spectrum. And for me, having, being a survivor in my personal life, I really like that they're working the survivorship aspect of it into it where, there's this whole world of post cardiac arrest care. In my instance, I'm a cancer survivor, but, having that survivorship aspect built out is vitally important. On the EMS side, that preparation thing, I don't think we've spent nearly enough time on it, whether it's having the right devices, having everybody integrated into the dispatch. So this might be something that preparedness side where I feel like we talk about it a lot, but we might not implement it enough. Danny, when we're building out systems here, looking at these recommendations, I guess what can we do on the preparedness side to at least kind of get the crews where they need to be before we get on scene for this?
It's not going to be popular, but I think we need to drill. I think we need to take a cue from the fire service and start applying drilling and training towards cardiac arrest survival. And in a tiered system like we have, that means your ALS people and your BLS people have to train together so that you understand what each person has to do and what each level has to offer to contribute to survival. This is what we're talking about. This is what's really important about this. And I think it gets glossed over with the, mechanical CPR, epinephrine, all this stuff. I think we're getting into a point where we have to realize this is a team effort. We have to work together to ensure maximum survival. And that means BLS, ALS, emergency department has to work together and has to understand each other's roles to integrate that so that we get a better continuum. I love what the AHA did with it, and I'm really interested to hear what Remle or Professor Crowe has to say
Professor
about
Doctor.
that. Professor Doctor.
Doctor Professor.
I think
I think
Remle's
it's
fine.
Professor.
well, what's interesting is I want to ask Remle how your work on burnout contributes to this, because obviously there's almost you can extrapolate this chain, almost indefinitely, right? Where you have preparation and then you have pre-preparation, right? Where do you have a staff that is mentally prepared to pursue this arrest? And then you can have like pre-preparation, where does your staff have the support at home, to be able to work effectively? So we can kind of build this out, but I wonder what you found as far as that's concerned of, it's easy to say, all right, it's 7:30 in the morning. The staff was able to get, a very healthy, balanced breakfast with whatever stimulant of their choice. And, we get called out to a cardiac arrest and everything goes fine. But the reality is that most of these are 3 o'clock in the morning with a staff that's been on an 18 or 24-hour shift that doesn't sleep enough. So I'm interested in what you thought about that, or what you found about that as far as the actual chain of survival itself.
Yeah, a couple of different components to this, and I like what was being said around the team aspects of this. And there's separate recommendations around in-hospital teams and out-of-hospital teams, but that interaction between the two is also key. The common thread on the teams, though, is to have assigned roles, and I think practicing those before game day is a really big piece of this, because in most systems, if not all, this is a low frequency but high criticality event. And we don't want to be reaching for that knowledge that we haven't dusted off in quite some time. When the event occurs, we've got to be ready. So I think that teamwork aspect is absolutely key. As far as the burnout aspects, there's a couple different places where these guidelines touch on things that could impact burnout. One of them being feedback. So my dissertation research was on burnout, and one of the key elements or the key job resources that can reduce burnout is receiving feedback. And it doesn't matter whether it's positive or negative, but this idea that somebody cares enough to help me in my work or to notice what I'm doing. And so there's information around debriefing and whether it's hot or cold. The evidence isn't one way or another, but the evidence is there that we should be doing and we should be providing this kind of continuous feedback. And that was associated, at least in my work, with a 30% reduction in burnout, whether that came from a supervisor or a medical director or a colleague. The other aspect, which you touched on, is most of our resuscitations are not going to have a favorable outcome. And the science is clear on what's best for the survivors is to stay on scene, resuscitate in place. And there's guidance in this chapter about resuscitation in place. However, if you're just going to go out there as a system and implement the evidence, you need to think about what other pieces of the system you just affected. And so by implementing termination on scene, which again, data is very clear that this is best practice, but who did I just affect? That 18-year-old EMT is going to have to tell somebody that their loved one is dead. And I don't know about you, but in EMT school, that was like a page in the textbook, and we flipped it really fast because it was uncomfortable, and we just hope it didn't happen to us.
Talk about this.
Nobody even touches it.
Yeah, we hoped it never happened to us.
If
we
you ignore it, it
didn't
goes away. That's how it works.
Right? And it will never happen to you if you just don't think about it. But it does happen to you, and it happens to you with a child, and it happens to you with somebody's father, mother, sister. All of these are really challenging notifications to make. So that was one of the key pieces of this is don't think of things in a vacuum. You can follow the best evidence and still cause harm if you're not considering how do I best equip my clinicians with the knowledge, skills, and abilities to feel confident and to know that they did the right thing and not have I should have said X, Y, or Z, or I didn't feel prepared to do that. And I think that's an area where, again, simulation, practicing that conversation beforehand can have a huge impact. And just to give a little bit of the data, because I'm a data nerd, again, burnout is my jam. We know that death notification, whether you're trained or not, is associated with burnout. And so delivering 1 to 5 death notifications was actually rather common. First of all, 1 out of 3 BLS clinicians had to do one in the past year, and about 3 out of 4 paramedics had to do one in the past year. So that's associated with 34% increase in odds of burnout. Meanwhile, if you have to do 5 or more, this goes up. It goes up to 74%. So we should be prepared for this. But the key finding was those who had received any modicum of training on how to deliver a death notification. And we didn't ask how good the training was or how long it was or anything, but
Just
any
something,
training,
anything.
anything, whether it was in your initial or your continuing education, was associated with a massive decrease in those odds of burnout. So this suggests that having the knowledge, skills, and abilities, or feeling confident, having somebody have told you how to do this, can make a big difference in what's a really challenging conversation. But the converse of that is you just run off to the hospital. That family, that survivor is traumatized now because they're not going to get to see that person. And you just kick off a bunch of negative chain of
Right.
events because I
And
was
now it's a problem
uncomfortable
for
having
30
that
people.
conversation.
Well, and
Exactly.
they also get their hopes up, right? Because
Oh,
if we're
absolutely.
transporting them, there's going to be a good outcome because they saw it on Grey's Anatomy.
That's
I
a
mean,
good point.
ABC, please don't sue us. But the reality is, the history of television says, oh, if you have cardiac arrest, you're fine. By the next,
Yeah, you'll
commercial
pop right
break,
up.
you're sitting in bed, not monitored, not intubated. You're having your lunch tray. Everybody's goofing around and joking, and everything's fine. And we know that's not the truth. We know that these people are severely debilitated. For them to walk out of the hospital takes an enormous effort from all aspects of the hospital staff, and we're not helping.
Yeah, and a lot of the cases tend to be like the case from Code 3 where they just walk in and like the patient is room temperature. So what are we doing here? But Mike, I want to kind of dovetail off of that and get into the feedback part and then get back into the termination stuff, which we talked about the termination in the last episode. But for feedback, I kind of want to emphasize the importance of like, this is a QA thing, but this isn't a punitive thing, right? This is, as you're working arrests in the field, you want to know, what are we doing well? What are we doing poorly?
Sure.
Whether that's, depth of compressions, whatever else. So talk to us a little bit about system stuff for feedback for cardiac arrest.
Yeah, I think, and Remle, please correct me if I'm wrong on this, but to my knowledge, most of the
Don't do
time,
it.
whenever
Let him flounder.
whenever you're correcting somebody,
on,
the rule of thumb that I was taught in my medical director's courses, EMS medical director's courses, is that, and in my experience, is that usually it's not necessarily a single provider issue or a single clinician issue. It's usually a systems related issue, especially when we're talking about cardiac arrest care and holes, in cardiac arrest care. So I think regardless, when you're giving feedback, framing it from that sort of mentality, you're not doing necessarily punitive feedback. Hopefully you have a just culture where people come to you approachably looking for feedback. I'm curious, in those systems where they do get some element of feedback, if it's just also the totality of being in a high performing EMS system where there is an element of feedback, as opposed to a system where you're just running jobs all day and you don't even get your charts QA'd and you don't know what your patients are doing or whatever else. So, I think feedback, to Remle's point, is a very, very critical component. I was even thinking way back when to 2010, sitting at Monmouth University in my psychology class.
Go Hawks.
Go Hawks. Thank you, Ed. To one of my emotional psychology classes, talking about how important partner feedback is, just even talking with your loved one on certain things and how much of an impact that can have on an interpersonal relationship. So to me, it does speak, wonders about just the element of feedback, letting people know what you think. But also, I think if you're taking this from like a supervisory role, a medical director role, or things along those lines, that's a perfect opportunity. If I'm on scene, or I alternatively, more often than not, I'm taking a medical direction phone call. If it's a high stakes call, cardiac arrest can be considered a high stakes call, certainly. I like to do a hot wash or at least a touch base afterwards with the crew just to check in with them. And that's something that was really impeded upon me, not necessarily by a physician, but by one of the excellent captains out at Albuquerque Fire Rescue, who just like touched base with all of his crews after a bad job or whatever it is. And this guy was like universally loved by everybody. But the reason I share that is by being available like that, by giving feedback all the time, your crews are also open when you're giving constructive feedback. You're not just some random Joe Schmo who's coming up to them saying, oh, your CPR fraction was crap, or you took 45 seconds to get the Lucas on and all that sort of stuff. Because, I remember back in the day, certain supervisors coming up to me who I've never even met, giving me feedback. And I'm like, go scratch. I don't care what you say. But
Who are you?
if it comes from someone who, number one, appears like they're invested within your personal success and also maybe the company, the department, whatever success, you're really going to take that back, number one, in a good way, hopefully. And then number two, it's also just a sign of a high performing agency that there is some element of feedback there. So I think that's all very important. I'm very pro it. I think, as has been sort of teased throughout a lot of the different things we talk about here, there's ways to do it right and there's ways to do it wrong. So if you're not comfortable giving feedback, there's tons of things. I'm going to be giving a webinar with NAEMSE soon on this, but there's tons of like structured models to do feedback for. I'm a big fan of the 1-minute preceptor. That's a way to do feedback in real time for those sorts of things. There's ways to talk through, a hot wash. So I would very much encourage people not to necessarily just like do it on a whim. Do a little bit of research if you can, a little bit of Googling, whatever else, and just look. You can even ask ChatGPT, what's the best way for me to give feedback to my crew, or the best way for me to give feedback to my student that's with me today.
Dear ChatGPT, help.
Essentially, but that's what it's there for.
Look, I became a much better person after the advent of ChatGPT. I say, make this email friendly and professional, and I've become a better person.
Right? All of a sudden, like I'm nice in all of my emails all of a sudden.
Oh, wow.
Who
Really?
knew?
I can do that?
I do it
Thank
all
you,
the time.
Microsoft Copilot.
Thank you, Sora. I always wondered what it was like to see historical figures in a wrestling ring.
Oh, I have to rethink things.
And then sort of like the other part of your question. Sorry, I was going to go on to the
Dan,
termination.
You're good, Mike. Go.
Yeah. So, the other part, I think all of us are very passionate about this clearly. I just recently wrote that paper, the editorial in pre-hospital emergency care with Dr. Brody and everybody. And I think, again, I'm not saying that as a point of pride. I'm just saying, I think the real big point of us writing that article is there really needs to be, in addition to some structured training about how to do death notifications on scene. I also think we're at a point within the expansion of EMS as a medical profession, at least within the United States, of really reframing the conversation, not necessarily as termination of resuscitation, but really about it with the withdrawal of life support, having family involved, really, because that does things for the crews, lets them know that, we're not just terminating our resuscitation. And sometimes I feel like that can have very hard verbiage around it that crews may and individuals may psychologically impact on. But also it says to the family and also says to the crews that we were performing life support, we were assisting, we were trying to help, we were doing our best. And even with everything against you, or even with everything working for you, that's sometimes just not enough. I think there needs to be
respond to treatment.
Right. I think there needs to be a couple of conversations off of that. Number one, we touched on this on our last episode a little bit. We definitely over resuscitate a lot of people who should not even be offered resuscitation.
Oh, absolutely.
That's a whole legal issue in and of itself in our country. And then also just the conversation about how we approach talking about termination of resuscitation or withdrawal of care on scene. I do think, again, similar to the point about feedback, if you got any training on this, that probably means that you're in a system that cares. So I'm curious that, that's probably part of it. But at the same time, like, any education you could do around something that can be uncomfortable, that is low frequency, the better. And similar thing, there are ways to approach having that conversation with family. In the article, we had a witness mnemonic that we recommend folks to use. That's what I use on scene. And essentially it's just, welcoming family in, showing everybody what happened, making sure everybody's on the same page, using calm, caring language with the family, meeting at them on an eye level, not talking down to them. There's tons of small nuances to having that conversation with patients that I will even say, as a medic of 10 years, I only really started feeling comfortable with my conversations about cardiac arrest and death probably my third year of emergency medicine residency. And that's because I was doing it a lot more frequently as a physician. Maybe I'm just a worse doctor than I was a medic, but I think why am I giving those conversations more? I don't know, but you're just doing it with more frequency, and there's lots of lessons learned by doing it the wrong way. And I think a lot of medics, as our profession within this country is getting more older now, that we have had a couple of generations now through of EMTs and paramedics, we're recognizing, hey, this is an area that we need to improve upon in pre-hospital care, because death care is still care, even though we're not performing active clinical care to a patient.
Sure.
And so once we get onto scene and we do all this kind of stuff, and Remle, I want to come back to you in a minute to get into TORs, but Dan, let's get into debriefs real quick, because that's another kind of big thing that we need to talk about. And so talk to us about the operations of that a little bit, and then we'll get back to Remle and Mike about the actual data behind it.
Well, my thing is, I love this idea. I love the idea of having a debrief, and I love having the idea of a hot wash after calls and taking everybody outside the house.
Just real quick, for the uninitiated,
saying,
for people that haven't heard what a hot wash is, before we start giving people the idea that we're actually deconning outside the hospital, let's just go over what a hot wash is real quick, just so everyone kind of understands the terminology.
So a hot wash is basically an informal debrief of a call that you were on, generally with the people that were involved. It happens generally after the call. And it's a quick thing. It's not designed to be this huge dissection of the incident. It's a minute or two. Hey, what worked? What didn't work? How can we communicate better? How can we do things better? I'm going to say that, if you watch The Pit, I think they do a really good job of showing you what a hot wash is. And they also do a really good job of explaining to patients' families what the course of the resuscitation is and what's going on and what's down the road. And if you want to do that, I think that's a really good place to start because the actors there do an excellent job, and the writers and the producers do a fantastic job of explaining to you what the optimum should be as a clinician. My question to the two doctors is, I work in a world where I'm in a tiered system. I interact with a ton of different agencies. It's kind of hard for me, as much as I would love to do what Dr. Robbie does in The Pit and say, hey, can we take a minute at the end of this resuscitation, recognize this person as a human, recognize that they had a family, that they had children, that blah, blah, blah. How do you incorporate that when, let's say, maybe your system's not interested, or maybe the people around you look at things from an old perspective of, oh, just another dead body, we're going to move on.
Or the system might have a mindset or a bias that you don't need to debrief or talk about it, right? It could be someone that they might just be mired in an old way.
Right. I'm going to point out in some shops, and I don't want to call out names, obviously, but there are places where if you do a resuscitation, you pronounce that patient post-resuscitation, it goes on your little MDC as a cancel.
Yeah. And you did great. Up and walk away to the next one.
And I think that's very disingenuous, and I think it's psychologically damaging. And I'd love to get your, Remle and Mike's perspective on this, because listen, I just spent 25 minutes trying to pull this person out of a cardiac arrest. It was unsuccessful, and now it gets marked as a cancel. What do you think about that? And how do we incorporate this into our individual practice if our systems are not, maybe they're not there yet?
And I'm curious what Mike thinks, but my first reaction to that is, if you're trying to move towards the evidence and towards what we think is a better way, and you're experiencing that kind of resistance, that's the time to get curious. What else is going on in that system that's driving that? Is it imposter syndrome? And they're afraid because they don't know how to have the debriefing conversation, and it's easier just to have the gallows humor and to move on and to be tough. Or what happened in that culture to drive that? That would be where I would start, is let's put on my curious hat and figure out what other things are at play. Because people do experience emotions in different ways, and offering a variety of ways for them to have that conversation. Some people don't want to do the hot wash. I just want to move on, get over, finish this. But, 3 or 4 days later, maybe now's the time I'm open to hearing about my compression fracture or whatever. So making different ways available. And then in busy systems, I know you can't be there for every single one of these. So how can you make sure that you are getting to people who would like to be gotten to, if that makes sense? So one way is in some of the EPCR systems, and I obviously have a bias, you can indicate that you've had a critical incident. And in that case, then we know who's flagged, who might like some help. And there's really great research on critical incidents. And Dina Ali just published an amazing book called Hope Out of Darkness that really digs into some of this around how do we do things like peer support. That's another great way to reach people. But having those mechanisms for people to flag how they want to be reached, obviously, like just calling somebody into your office in front of everybody could have the opposite effect and could serve to embarrass that person or make them hesitate to report something. Because critical incident, not all cardiac arrests are a critical incident, and it's an individual's experience of the event, not the event itself. So I think that's something to keep in mind as we think about feedback and debriefing. And Mike, I'm very interested in also your thoughts and experience on this.
Yeah, I think you brought up some great points. Number one, if someone does not want to participate, don't force them to participate. I think that's like a very salient thing. Some people are just not receptive in the moment or handle grief very differently. And, some people just don't want to talk about it in the immediate, post period, which is fine. I do agree with you. I think, you're touching on what else is going on in the system is very salient. I don't necessarily have an EMS specific story to share, but over my last year and a half in particular, done a lot of traveling, working in a lot of different ERs, meaning I was not necessarily, I was an ER doctor, but not established with my team. They didn't know who I was compared to a fly on the wall. But this is a practice I like to do with all of my resuscitations, especially my sicker ones, not necessarily just cardiac arrest, but taking a lesson from one smaller critical access hospital I worked in, we had a pretty gnarly cardiac arrest that I ended up pronouncing. And it was me, a couple of nurses, RT, the intensivist came down. Um, and I did all my usual stuff. We paused for respect, talked with everybody, asked how things were. And someone, I remember one of the nurses pulled me aside and was like, "We have never done that before. And thank you for doing that. Like, it really helped me a lot, like talk about these things." And I did, something with the ultrasound she'd never seen before and was very curious about that, and ended up in a whole separate education discussion. The reason I share that is sometimes you just need to just do it. You just need to walk the walk and talk the talk and be the change that you want to see and represent the type of system that you want to be in. That may not be feasible for everybody if you feel intimidated maybe by your coworkers or saying things like that. I'm not saying necessarily put yourself in an uncomfortable position, but if you feel like you have the ability, the wherewithal, and the support maybe from your partner or other colleagues to like stand up and be the change you want to see, I would very much encourage you to do that, because oftentimes change is not going to start occurring until people start doing the things. And that just could be with you. It could literally start with you to just be the change you want to see as far as how you manage those hot washes or whatever else. There is some literature out there that CISD may not be as beneficial for all folks afterwards. And I think part of that again is like forcing people to do something they may not necessarily want to do. So don't like try to pigeonhole everybody into cooperating with you. But if it is something that you want to see, it's how it trials. I think just like starting to do it after like a cardiac arrest or like a critical call would not be a bad place to start with the people that decide to stay and just see how it goes.
So I think an interesting kind of tack to take on that is I think that it's very easy to look at a document like this and say, all right, it's calling for systems overhaul, thus we have to overhaul the entire system. And with something like debriefing, this isn't something that you necessarily need to have an established policy for, right? If you're a supervisor on the road, it's a phone call, it's stopping at the hospital and saying, "Hey, like, are you guys good?" And you might have 85-90% of your crew that is like, "I'm fine, I'm super not interested in discussing it." And that could be they're not interested in discussing the call, they're not accustomed to having that type of feedback, they don't want to discuss it with you personally, which isn't necessarily a personal attack, it's just kind of the world that we're living in. So there's a lot of different variables that we have to take here. I think it's a really important point that you can't force people to be debriefed. I think that's a really important thing. I think that kind of adds to the stress of it. Like, no, you're going to sit and you're going to talk about it right now. I don't know that solves anything. But I think and we've talked a lot on the show of how if you've seen one system, you've seen one system. So what works for your system is what's going to have to work for your system. But I want to kind of reinforce that this doesn't have to be someone at the top of your organization saying, all right, policy 1.594 says that you can debrief at these times, right?
Yeah.
It all, and again, this is whatever platitude you want to add to it, right? Like, you're a leader, whether or not you're in leadership, right? Like, you can just walk, like, even working as a medic, you can go up to your BLS staff, be like, "Are you guys good? Like, that arrest was kind of
100%.
stressful."
Yes.
And just have that conversation. And I think it's wildly important. And, we spent a half hour going through this stuff now, and certainly we can spend hours going over the rest of it. And certainly Remle has spent years going over it.
Ed.
But before we wrap up, I do want to talk about there's some time that's spent on equity and social determinants of health, and then also clarification on emerging technologies. So social determinants of health, it's kind of it's a woke thing that we're doing now.
Come on, man.
So it's super,
and
super
40% of our audience just turned off the show.
I know you like that. So, no, we're going to clip that for the socials. No, so social determinants of health are wildly important in all aspects of medicine. And it's certainly something that we see in EMS, and we talk about it all the time. You can have a family that's living in poverty. They're not able to get their medicine, so their chronic illness is exacerbated. I think we've sort of talked about it in classes, and CME and all that stuff. But Remle, talk to us about how that actually gets involved in the new AHA guidelines and what that means, what that changes.
Yeah, so a couple of different things here as well. And social determinants of health is perfectly fine terminology, but there's a recent movement that I'm kind of liking, if I'm honest, where they're asking us to call it social drivers of health because determinant sounds fatalistic, like you'll
Just
never
and
change it
drivers,
and you're just
yeah,
stuck.
That's not bad.
So
I
I mean,
like
I'm
it.
kind of, and that language may have not been around at the time that we were working on this, but I'm liking
It
that
also kind of
aspect.
sounds like an Austin indie band too. I can
It
get
might
behind
be.
that.
We keep it weird in Austin, that's for sure.
South by Southwest next year, headliner.
Yeah, absolutely. But I think we can't talk about cardiac arrest without talking about SDOH, whether it's drivers or determinants, because the environment where you live and work and play and learn and all of those things has a drastic impact on your health. Your medical
Sure.
care is only a small fraction of your outcomes. And I'm sure some of you have seen there's a really interesting YouTube video about a tale of two zip codes and two people with really similar characteristics. The only thing
Yep.
that differs is their zip code. And the only thing is in air quotes there because obviously lots of things differ because, based
And there's
in
millions of
association of where you live,
stories.
not causal.
Yeah, and like there's
Um,
millions of stories in the business world where I don't remember the names, but resumes with names like Michael and
Yeah.
like Deshaun were put out, and they're just based on names and whatever. So it's
Well,
Remle
Ed,
or
we-
Remle. They think I'm a
Ed,
man
we-
a lot, and that
if you-
actually maybe
if
helps
you-
me. They type, I have a nickel for every Mr. Crowe email I get, but now I'm really snarky and I just reply, actually, it's doctor.
It's doctor.
Love it. Ed, do you remember the journal club we did on YouTube where we talked about the responses into Southie for the trauma? And this paper folded right into this issue. And, social drivers of health. I love that new term. I'm going to start using it. You can't be in healthcare and not understand what your community goes through.
Oh, yeah.
What is being inflicted on your community? What are the struggles they're dealing with? It's not woke. It's understanding what the people you serve are going through. And it
Right.
makes you better because you understand. I don't understand what the pushback is on this. This makes a ton of sense.
Well, and we have somebody here, and Remle, not to take away from your time. Certainly, you've traveled the world too. But Mike, you've worked EM and EMS in large urban cities, in large kind of outlying areas. I'm sure that you've seen that each system has their own specific needs. I'm sure the system in Manhattan works a little bit different than a system outside of Albuquerque.
Yeah, very, very
Maybe.
much so. The one thing that was like coming to my mind during all of this was like, even, not even talking about like actual, like, health maladies, but even your CPR prep courses are very different depending what population you're teaching.
Yeah,
I've
not a lot
had
of
the-
30-story high rises, in the outskirts of the desert.
or whatever their beliefs are. Like I've had the pleasure of teaching out in Navajo Nation and like other, extremely rural communities.
I didn't even
and
think
very
about that.
deep-
Yeah.
very deeply Hispanic communities with very mixed different beliefs and like culture. Some cultures it's very, you don't touch the dead and you're not going to start CPR or, so how do you even go about doing community outreach in some of those places without understanding the different social aspects that are involved with that? And I think honestly, if you're listening to this, if you're one of those people who was tempted to turn off the podcast, but did not turn off the podcast and you're still here,
Nobody turned it off. They all know what they're listening to.
to be the
They're
best
just on the
clinician-
treadmill. They're doing their thing. It's fine.
to be the best clinician that you can be, you really need to understand all the different challenges that your patient faces. And I definitively remember times working, especially in certain urban systems with certain populations of patients, where certain clinicians are like, well, this is how it was, this is how it's going to be, and this is how it will always be. And that is not an excuse necessarily to provide substandard care and non-tailored care. I think the way I'm interpreting this as a medical director, as far as, incorporating your social drivers of health into your cardiac arrest guidelines management and resuscitation, is taking in all those peculiarities of the communities you work in, all those things that are wonderful that make us different, but also some of those things that are like mind-numbing that make you want to claw your eyes out. Like, why can't this patient just afford their losartan or their insulin or things like that? Like, those are very important things.
And it's such a large, complicated conversation. I mean, we're having it right now, but it's such a large, complicated conversation to say, like, because it is really easy to be like, I don't understand why you're not just compliant to your medicine.
Right.
And I'm like, well, they might not have, if they work for the government up until today, as we're recording it, they might not have gotten a paycheck in the past month.
And I think just breezing over this when you're, let's say developing protocols or developing educational curricula or developing community outreach curricula or whatever it is that you really can't breeze over these things because they will impact your care. And I
Sure.
think also when you're looking at how can you improve as a system, let's say there are systems I worked where virtually every cardiac arrest patient is hyperkalemic from missed dialysis because they haven't gone to dialysis. So, having a specific protocol would be very community centered on likely hyperkalemic arrests in your system. Yeah, so just using that as an example. So, there are very good ways to improve your care by recognizing your social drivers of health. And I was very glad to see a very strong position on that from the AHA personally. Thank you,
And
Remle.
I think it's vitally important where it's the act of starting an IV might be the same regardless of what patient you see, but the reason you're starting the IV changes from zip code to zip code and area code to area code. Go ahead, Dan.
You have to understand the people you take care of
Yep.
to take care of them. You can't just apply an algorithm or a formula to every person you see and make it work. There's nuance. It's what makes us clinicians. We have to do this. This is important. And I'm really happy that they've started to address this, because when I was coming up, we never did any of this. It was just a human figure, and this is what they were, and this is what you did. But you have to understand it. And, Mike made a great point about, oh, why aren't they compliant? I hate using that. I don't use compliant with medication.
Yeah, there's nobody that wakes up and says, I'm not taking my medicine today.
Yeah, right? Like, do you think that they
Yeah,
want to?
yeah, okay. Well, all right. It depends on the medicine. It depends on the medicine.
All right. But bear with me a second, Ed. Like, do we actually think that people who have the ability to don't want to take care of themselves?
Right. And I think that's the thing. And it contributes to burnout and all that other stuff, right?
Yeah.
Where it's, it becomes this self-consuming cycle where, you might, and the easy example is in a city, right? You have an asthmatic that is low income. So they're not able to afford their medicine, so they have to go to the hospital. But the hospital bills generate, collections, so they can't afford the hospital bills, so they can't afford their medicine. So they have to go back to the hospital. So they can't. And it's a system where no one in that system can fix it, right?
Right.
But
I know medics that I have gone to calls with, and statute of limitations is way gone. So come at me. Where we had patients who were having asthma attacks that couldn't afford it, that couldn't afford to get their rescue inhaler, couldn't afford their albuterol, couldn't afford their Duonebs, and didn't want to go to the hospital and refused. And I'm going to tell you, it's not where I work now. It's not where I worked before. It's way in the past.
Another place.
Don't come at me. There may or may not have been a nebulizer and some albuterol that fell out of the
fell out of the bag
and just ended up on the on the table. And
listen, man, the world's in a perfect place. Stuff falls out of bags all the time.
I'm just going to say this. If we're the greatest country in the world, that shouldn't happen ever.
Oh, that's a whole other podcast, and we don't have 19 hours to cover that.
I know, but I just wanted to start drama. I was just in that mood.
But it's a really important point, right? Because again, I think it's very easy in EMS, especially like I said, if you work in an urban environment where like, all right, we're going to 123 Main Street again. And it's all right, again, it's multifaceted, but we have to kind of look at like, all right, it's not so much that the patient is looking to abuse the 911 system as the system itself may have actually failed the patient. One last thing I want to get to before we get out of here, because the big thing that everyone kind of lost their minds about that we talked about a couple weeks ago is clarifying emerging technologies and interventions. Now, I'm to understand that there was a small piece of drama.
You're doing this again?
No, so we already talked about the mechanical CPR device aspect of this, but Remle, I want to get into what we actually talked about looking at and analyzing these new technologies when they actually come out. I think that essentially what it says is like, yeah, new technology is great, but we have to analyze it to make sure it works, which is kind of why everyone got so upset over this mechanical CPR thing, because it was really more of an analysis of, well, we wanted to see if it works, and it doesn't. So and I know that data is hard to refute, and Remle, I know that you're very wishy-washy on data, so let us know your take on that.
Yeah, I have some opinions. No, I think the emerging technology
Do
piece, like, do I? It's my second favorite
do you?
four-letter word next to taco. Let's be clear. But so the emerging technologies, I think the message there is for, and it's funny, I just had a conversation earlier about the innovation and the adoption curve. So you've got your early movers who are, far over on one side of the curve, and then you have your laggards who are not going to do it until everybody else has already done it. The magic happens somewhere in the middle where more start to adopt and we can measure and we can make sure that the thing that sounded really good in theory is actually resulting in really good results. Because a lot of times, one of the things that really gives us burnout is a lack of hope. Why is it so hard to take care of patients that we go to for the
Yeah,
125th
Right.
time?
Why
Because
is
we
our
don't have
resuscitation
hope.
rate 10%? Yeah.
Yeah, right. So that, and anytime something flashy and shiny gives us just a little bit of hope that it might be that thing that brings us better outcomes, the temptation is to jump the curve and to go
Mm.
straight to adoption. But we should be testing things on a small scale. We need to test them in the environment where they're going to be used and make sure that the data actually supports that really good idea that somebody had. And in EMS, we love really good ideas. We got into this to help people. Of course, we want a solution. So I think, again, it's an altruistic situation, but too often we want that to be the silver bullet and we jump straight to it, and we actually might have unintended consequences, and that's where having a balancing measure is really important. And we saw that sometimes with the mechanical CPR. Nothing against the
Mhm.
mechanical CPR, but if we focus everything right there, what else falls off? Oh, well, we stopped compressions for too long and we learned we
Mhm.
need to do choreography and we need to practice that. So having that data helped us get better and helped us have a continuous system of improvement. But without the data, we're just guessing and going with really good theories and hunches and ideas.
Mhm.
I think and we're going to get out of here in a second, but I think one of the most important or one of the more interesting things that came out of this was as soon as this data came out, and this is a group of 4 people who understand like the data is the data. It's it's non-biased. It doesn't have an opinion. It just is. I think a lot
But
of people
is it
immediately
extant?
jump right. But a lot of people like jump to the conclusion of like, no, 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 no. I get ROSC on 90% of my patients using mechanical CPR. And I think it's kind of like, all right, well, the AHA update isn't Crowe saying Steve Smith is bad at resuscitation. That's that's not what this document was. So
Yeah.
I think it's going through is like, no, no, no. It might be that automated CPR devices are the future of resuscitation. Right now, the data doesn't show that, and
Right.
maybe we need better data sets. But there it's the kind of thing of like this isn't a a broad sweeping like never again. This is like, yeah, there's
We
a
need
place for it, but it's the same
Ed,
thing like like
we
going back
need
like Stokes
independent
baskets and
data.
and like scoop stretchers. We don't need them, but we should have them for a thing.
But
And you're right,
but Ed,
Dan. The independent
we
data thing is
need
important.
yes. We need independent data. I don't need data from, and you and I just went through this at our shop with our competencies where we had our manufacturer rep in, and I'm not telling you who, and they were like, well, this works and this is great. And I was sitting in the room and everybody's going, oh, wow, well, there's data. It must be good. And then you find out that it's a small sample size and it's, it was funded by the people who made the device. So they have a
Mhm.
vested interest in it. There's bias everywhere. And, this is another problem with EMS clinicians. No one teaches people how to read a paper. No one
Oh
teaches
no.
people how to understand research. And, this stuff is getting put up at, programs across the country where you have these PowerPoint slides because somebody made them. They must be real,
and
right?
and they put time and
And
money into it. We spent money on it, so it has to be good. We need to use
and
it.
and I'm one of the lucky ones in EMS that I learned how to read a paper. And I'm looking at this and going, oh, dude, there's bias everywhere. And
Yeah.
you have a sample size of 22. Like, right, fine. But
Well, and
I
it's
don't know that
very
we
much
need to make decisions based on that.
yeah.
Most of our colleagues don't understand that. And, like we can go to Skeptic's Guide to Emergency Medicine. There's plenty of people who do good breakdowns of research, and we need to teach this in EMS. There's tons of stuff in EMS. We don't teach people, listen, we teach them rope rescue. We don't teach them to tell Listen, I can put a fireman on a rope. That's fine.
Right. Yeah.
I need an EMS clinician to be able to understand a paper
Yeah.
and what
I
it
think
means.
I think that that's something that again, we could spend hours going into this because I think
Of
it's
course.
very easy to be like, well, if you keep the masses illiterate, it's easy to control systems, and we have a whole big thing. But
Are we seizing the means of production?
Not yet. We're getting there, though. But again, this huge AHA update, very, very important stuff. Remle, thank you so much for joining the show again. Mike, Dan, this was a great episode.
Stuff.
Really, really exciting stuff
Great
to get
stuff.
all this information out. For those of you that haven't seen us at conferences, go do that. And we got a whole bunch of other stuff on there. Subscribe down below on YouTube. And for the overrun, and for Dan and Mike, and for everybody, we'll talk to you all next time.
Take care.